actually going to be in a series of maybe 3 or 4 presentations. Today I'm going to talk about pressure ulcers, which I would say are the most common types of wounds we see in home care. So let's get started. Okay. All right. Pressure ulcer stats. About 1 to 3 million Americans are affected by pressure ulcers. The healthcare expenditure is close to about $5 billion a year. More than 17,000 lawsuits related to pressure ulcers are filed annually. And of course, our elderly patients are at the highest risk of developing pressure ulcers. So approximately 70% of all pressure ulcers occur in the geriatric population. With our aging population, the chronic diseases that they have, which, naming diabetes, peripheral vascular disease, these are becoming increasingly common, and those are causing a lot of issues with their skin and the skin breakdowns. Chronic ulcers are forming frequently. Chronic wounds in elderly. A chronic wound can be defined as one that fails to proceed through a repair process within a period of 3 months. Chronic wounds are classified into 4 categories: pressure ulcers, diabetic ulcers, venous ulcers, and arterial insufficiency ulcers. But today we're going to talk about pressure ulcers. I think this skipped. Give me 1 second, folks. I think this skipped. Okay, pressure ulcers. Also known as bed sores and decubitus ulcers, these are injuries to the skin and the underlying tissue resulting from prolonged pressure on the skin. Bed sores most often develop on skin that covers the bony areas of the body, such as the heels, ankles, hips, sacrum, spine, shoulder blades, the back of the head. Risk factors are, of course, immobility, poor nutrition and hydration, medical conditions that prevent proper blood flow, and the lack of sensory perception. Warning signs of pressure ulcers are any unusual changes in skin color or texture, swelling, pus-like draining, an area of skin that feels cooler or warmer to the touch than other areas, and tender areas. I talked about the most common locations. Once again, the heels, the sacrum, spine, elbows, shoulder blades, back of the head. Most of our elderly population, our elderly patients, are lying in bed. Frequent turning and positioning. If that doesn't happen, these are the areas that have the potential for that skin breakdown and developing those pressure ulcers. So, pressure ulcers are actually categorized into 4 stages. Stage 1 is when the skin is not broken, but it is inflamed. Stage 2 is when the skin is broken to epidermis or dermis. Stage 3, the ulcer extends to the subcutaneous fat layer. And stage 4 is when the ulcer extends to muscle or bone. Okay. My next slide, I talk about these 4 stages, but in much of a detail, and I also have some, I would say graphic pictures of the ulcers. If you are sitting in front of this presentation, you can see this. If you're listening over the phone, when you get back to this presentation, you can see these 4 stages, and you can see the graphic representation of these ulcers. The pressure ulcer treatment. Bed sores are actually difficult to treat, but if you have the right treatment, if you choose the right dressing for the wound, along with reducing pressure on the sore by frequent changes in position, there is a potential for these pressure ulcers to heal well. My next slide, I gave you a chart of the most common dressings and the wound care types that are used for pressure ulcers. This is just a good reference guide for all those clinicians who are out there and they see these pressure ulcers, they see these wound care types, just to get an idea of, what is the most common wound care dressing and the treatment out there for which stage of the ulcer. But I'm going to talk about this in detail in my next few slides. So stage 1 pressure ulcer treatment is usually done by using a transparent film. I have a picture of a transparent film, basically a tegaderm that you can just cover. The indications is this is a primary and secondary dressing. It could be used for stage 1 and stage 2 ulcers, mostly for non-draining ulcers. The advantages of tegaderm, of a transparent film, is it's ready wound inspection because it is transparent. You can see actually underneath what's going on with the pressure ulcer. It's watertight. It prevents or reduces friction, and you can change it every 5 to 7 days. The disadvantages is it may adhere to wound. It's non-absorptive and may adhere to the wound. So stage 1 pressure ulcer treatment, what else do? We offload the client, we offload the pressure ulcer site, stay off that area and remove all pressure, keep the area clean and dry, eat adequate calories and high in protein, vitamins, and minerals, drink more water, find and remove the cause, inspect the area at least twice a day, call the healthcare provider if it has not gone away in 2 to 3 days. The healing time for stage 1 pressure ulcer, it can be reversed in about 3 days if all pressure is taken off the site. So as clinicians, when we are meeting with our caregivers, and if we are inspecting the skin and we see an area that looks suspicious and we feel that this is a potential for a pressure ulcer, it looks like a stage 1, but if it is not taken care of, it can progress to a stage 2 or stage 3. It is very important that we talk to our caregivers and we educate them on offloading from that pressure site, taking good care of that area, and of course, adequate nutrition and hydration is always important. So for stage 2, once again, I have a picture of a sample of dressing that is most commonly used. It's a hydrocolloid dressing, which is an opaque or transparent dressing for wounds. A hydrocolloid dressing is biodegradable. It's non-breathable, and it adheres to the skin, so no separate taping is needed. Hydrocolloids are a type of dressing containing gel-forming agents, forming an absorbent, self-adhesive, waterproof vapor. The gel formed when exudate is absorbed maintains a moist wound dressing while preventing fluid accumulation on the wound surface. These wound dressings may not be suitable for wounds with heavy drainage. So anything for stage 2, if it has a moderate amount of drainage, hydrocolloid dressings are suitable for these type of ulcers. Unless if it is a heavy draining wound, then we talk about foams and other dressing types. But for stage 2, if it has a moderate amount of drainage, hydrocolloid dressing works beautifully. Once again, what to do besides the hydrocolloid dressing changes. You get the pressure off. We follow all the steps that we talked about in stage 1, nutrition, hydration, offloading, taking care of the client, just maintaining a good, I would say, turning and positioning schedule, and, just making sure that the skin is inspected routinely. The healing time for stage 2 would be 3 days to 3 weeks. Stage 3 and 4 pressure ulcer treatment. The goal of treatment for stage 3 and 4 pressure ulcers is to properly debride and dress the wound cavity, create or maintain moisture for optimal healing, and protect the wound from infection. So now stage 4, if you recall, it goes all the way down and you can see the bone. It's that deep. So it is important to make sure that it's properly debrided and the wound cavity is dressed properly as well. The goal of properly unloading pressure from the area still applies. At these pressure ulcer stages, more emphasis should be placed on proper nutrition and hydration to support wound healing. Surgery may be necessary to close the wound in some cases. For stage 3 and 4 pressure ulcer treatment, alginate dressings are most commonly used. Alginate dressings are dry when initially placed on an open wound, and they become larger and more gel-like as they draw in fluid. This helps clear out the wound. It prevents it from becoming dry and protects it from harmful bacteria, which helps lower the risk of infection. These dressings also help promote new skin growth during the wound healing process by ensuring that the wound area stays moist. Change the dressing every 1 to 3 days or when fluid starts to seep out from the edges of the dressings. So alginate dressings are go-to for stage 4 pressure ulcer. For pressure ulcers that are infected or ulcers that are at high risk of infection, silver alginate dressings minimize bacterial contamination. So that's another thing to remember. If it is an infected stage 4 or stage 3, silver alginate dressings are most commonly used. Foam dressings are highly absorbent, so any stage 4, stage 3, or stage 4 that are highly draining, have heavy drainage, foam is used. So the foams are absorbent, and they're generally less, there's less need to change them frequently. Patients typically only need to change the foam dressing every 2 to 4 days. They're often used for highly leaky wounds, as I said, typically during the inflammatory wound healing stage when drainage is at its peak. However, if there's too little drainage, the foam dressing can cause a drying effect that can be bad for the healing process. So if it's, once again, foam dressing only for heavily draining wounds, if the wound is not draining that well, putting a foam in there will soak up all the moisture, and that won't be good for the wound. So for our services and the caregivers and the clinicians, as clinicians, when we go and we see a patient, a client, and there is a potential for skin breakdown, the patient is not, is not moving well, is lying on the bed, what are some teaching points? What are some educational opportunities we have with the caregivers? What are our talking points? Of course, frequent changing of the position, turning and repositioning, adequate nutrition, hydration, inspecting the skin routinely. For clinicians, you would obviously use a Braden scale to assess the risk for developing pressure ulcers. You will design a comprehensive and an individualized plan of care. We talked about developing a specific tool which will encompass these talking points, these risk assessments, what are the things that we can do for our clients, having that sort of a tool ready for our clinicians when they go in and see our clients and talk to the caregivers. They can utilize that tool and to educate the caregivers on these are the specific things you should be looking for or you should be doing for this client. I will be working on developing that tool. I believe I should have it within the next 2 weeks or so. And I would really encourage all the clinicians to use that tool when you go and visit your clients. You will instruct caregivers on pressure ulcer prevention strategies. We talked about proper nutrition and hydration, and also communicating the progress or changes with our healthcare partners. Now, I know for most of our agencies, for most of our branches, we may not be providing the wound care. It could be a certified home health agency or the nurses in the wellness department of the assisted living facilities, or it could be us for our Medicare certified agency. If you are not providing the wound care, you're still inspecting the skin, you are guiding the caregivers, in caring for that patient in pressure ulcer prevention strategies. You're partnering with these external agencies, the CHA, the physicians, and the ALF, in letting them know, okay, you know, I went to see this patient, I did the assessment, there's a risk for a pressure ulcer. Let them intervene as quickly as possible. These are the things that you will document. These are the things that you will monitor and assess for. In terms of, give me one second, I think my slides are just not working properly here. Okay. I apologize, folks. Nope. Okay. Anyhow, just a quick recap. Once again, 4 stages of pressure ulcer: stage 1, stage 2, 3, and 4. You know, I talked about the treatment plans. I talked about different dressing types. There's a chart in here of various different dressing types you may use for different stages. As always, offload the pressure, nutrition, hydration, use accurate risk assessments, and educate your caregivers on these prevention strategies. Any questions? That brings me to the end of the presentation. Any questions?
I'm gonna unmute everybody. I see we have a comment in the chat box. Do you see the chat box, Joy? It says, from Arthur, it's important to ensure the client has the appropriate mattress in place, for example, a group mattress such as an air mattress, etc. Arthur, do you want to talk about that for a minute? Okay. That's a very good point. Okay, I don't know if there are any other questions. Anyone have any other questions for Joy or comments? All right, thanks very much again, everybody. We really appreciate your participation today. And we will, as Joy said, have a series of calls on wounds. This is the first of a series, but we'll probably do it quarterly. So the next call related to wounds will be in a couple weeks, months rather. So stay tuned for February's topic. And thanks again, everyone. Have a wonderful day.